today. So I'm going to be presenting on an assisted walking program. This was a randomized trial published within the last year in the Journal of the American Geriatric Society. I have no conflicts of interest. So my goal today is to review the evidence for targeted mobility interventions for hospitalized older adults in acute care. I think an issue that we can all agree is a big one. Then I'm going to be presenting the study and critically appraising the study's methods and results, and then discussing the study's implications for clinical practice. So firstly, I think we would all agree there is an epidemic of immobility in our hospitals. This is ongoing throughout the pandemic and probably worsening. So we know that hospital admissions are a major contributor to disability. More than half of older adults do not recover their pre-admission functional levels 1 year after discharge, and acutely hospitalized older patients do spend most of their time in bed, which is likely due to several factors, like the notion that reduced mobility prevents falls, or this culture of bed rest that we are still facing, as well as issues with hospital design and failure to apply efficient models for management of older patients, like ACE models, for example. So the evidence for mobility intervention, I'm just going to present a couple similar studies last few years. So first, this was a 2014 preliminary sort of data trial published in the Journal of the American Geriatric Society. They had 120 patients. This was not randomized, but they had a targeted gait and balance intervention program. And it showed that this program was feasible and there were less discharges to nursing homes. Sorry, there's going to be a trial coming from this STRIDE program probably in the next year or so. And then there was this trial, which was published in JAMA Internal Medicine. This was 100 patients. The mean age was about 73. And this was an ambulation program twice daily, as well as behaviors to increase mobility. And there was no impact on ADL function in this trial, but they were able to improve community mobility after the person was discharged. And then the one that has most recently been published, which I think many of you may have been aware of, I think it was in 2019. This was the effective exercise intervention on functional decline in very elderly patients. There were lots of nonagenarians and octogenarians in this RCT, and this was a bigger trial, 370 patients, where they showed that individualized moderate intensity exercise, both walking and resistance, improved the Barthel index and the short performance physical battery scores. So that's a bit of the sort of background of some of the evidence that exists for mobility interventions. And then today I'm going to be presenting this study, which is an assisted walking program on walking ability in in-hospital geriatric patients. The study objective was to determine whether an individualized assisted walking program for hospitalized older people, which was delivered by a trained registered nurse, so not a physiotherapist or an occupational therapist, and to see whether this could improve walking ability compared with usual care. This was an open label, non-blinded, single center randomized control trial, which was undertaken in a 32-bed acute geriatric unit in Bologna, Italy. Patients were randomly assigned to the walking program or the control group, which was usual care, and the inclusion criteria were any patient admitted to this unit 65 years and older and able to walk on admission. The exclusion criteria was independent walking ability at admission, any diagnosis of stroke or femoral fractures, which has its own rehab pathway. And of course, coma and severe dementia were also excluded. They didn't define severe dementia, though. Also, people that could not provide consent were excluded. So the procedures. So in the intervention group, there was a trained nurse, a trained registered nurse who provided daily 20 to 30-minute sessions of either dangling, standing, or walking from the first day of admission until the day before discharge. They did say that this intervention was suspended for some conditions, no details provided there. And I think it's important to know that this was a trained nurse, and this was a unit where they did not have physio and occupational therapy already. Those sort of allied health members were not funded in this hospital, and I think that's an issue across some parts of Italy, actually. But anyway, so they were sort of providing the intervention, and the other part was that they also provided motivation and education to the patients and caregivers about normalizing walking during the hospital stay. And then the control group was usual care, where patients were encouraged and helped to get out of bed and to sit up in a chair, or perhaps they were helped to walk to the bathroom, but there was no extra walking outside of this. The primary outcome was something called the Braden Activity Subscale, which is a 4-point scale that it seems like they already use in this setting. So that was easy for them. And it was a change in walking ability from hospital admission, both at the time of hospital admission as well as 2 weeks prior to discharge. So this is a 4-point scale. It's pretty simple to use. You can just see it right there. Number 1 is confined to bed, and then it sort of increases in function until 4 is walking outside the room at least twice per day. And then they had some secondary endpoints related to potential adverse events related to more walking, like falls or pain. And then they also looked at mortality and length of hospital stay. So they assessed over 1,300 people for eligibility. They excluded 970. You can see the numbers there. 130 had severe dementia. They ended up randomizing 387 patients in this trial with about equal numbers in the intervention and the control group. You can see that similar numbers, 9 and 10, did not receive the intervention because they died during hospitalization. So similar numbers died in each group. Okay, so these are the results. So I haven't shown table 1 because it was just really big, but the baseline characteristics were similar between the two groups. On this side, you can see the intention to treat analysis, and then there's also, they did a per protocol analysis as well. The results are very similar. Essentially in the intention to treat analysis, the intervention group showed a significant improvement in walking ability compared with the assessment at hospital admission. They said here that 73% of the intervention group versus 47% of the control group, their walking ability had increased by 2 or 3 points on the BAS. You can see this was largely driven by those in the 3-point category who gained 3 points in the BAS. The numbers who gained 2 points were actually similar between the control and intervention groups. And then at the bottom here, this is the comparison of discharge BAS to 2 weeks before admission. And you can see here that the patients with essentially no change from baseline to discharge was significantly different between groups, about 68% versus 23% in the control group. Per protocol analysis was very much the same, so I won't get into that right now. Okay, so critical appraisal time. Was the assignment of patients to treatment randomized? Yes, it was. There was a centralized third party responsible for the randomization. They used an online system with opaque concealed envelopes. Were the groups similar at the start of the trial? Yes, the baseline characteristics were similar. Although, to be honest, we know that the age was similar and some functional measures were similar, but they didn't collect things like comorbidities, dementia. Like, we have no idea about those important information. So we don't know, but from what they've presented, they're similar. And then aside from the allocated treatment, were the groups treated equally? This is a bit unclear if the intervention groups received any additional attention and care because it was an unblinded trial. So And then looking at the analysis, were all patients accounted for? So they performed both an intention to treat and a per protocol analysis. Similar numbers died. So I would say, yes, the patients were accounted for. This was not a blinded trial, so all investigators were aware of group assignment. The important thing also is that the primary outcome assessment was done by the trained nurse and the unit geriatrician who were aware of group assignments. It was not done by masked outcomes assessors, which is a pretty big issue. And then the other issue is that the pre-admission walking ability 2 weeks before admission was indirectly measured. So there's a high risk of bias because it's retrospective. How large was the treatment effect? I'd say it was fairly large. I mean, a 2 to 3 point increase on the BAS is actually pretty significant. That's going from like being confined to bed almost to walking outside the room. Just a reminder here that the mobility sessions were a mean time of 32 minutes, but they didn't actually measure the mobility time in the control group. So we don't know how much those people were walking. There were no differences in the secondary outcomes, and this was underpowered to detect adverse events. And then the other issue is that in some ways, I mean, I would say in terms of external validity, there are lots of questions here. This was an older group of patients with the mean age of 86. So that's similar to our patients. The mean length of stay was perhaps a little longer than we would expect in acute care, although maybe in some ACE units it's similar, but I thought that was a bit longer than usual. And there was no information about underlying dementia, comorbidities, frailty. So we really don't know what these patients looked like, although we assume they're relatively frail, but we don't know. And then the other issue is that this was done in an acute care setting that didn't already have physio or OT. So that raises lots of questions about whether this is just trying to prove what we already do in our settings. Also, this was not the patient's bedside nurse. So this is something that requires extra resources. This was an extra trained nurse. And then were all patient important outcomes considered? I would say no. There was no information about discharge location, readmission rates, quality of life outcomes. They didn't look at cognitive outcomes. They didn't look at delirium. And even the functional outcome that they looked at was not a commonly used functional outcome like the FIM or the Barthel Index or the short performance physical battery. So the bottom line is that this is a mobility program of 30 minutes per session in hospitalized older adults for a mean number of 5 days over a mean length of stay of 11 days. And this was shown to improve walking ability from admission to discharge. I would say that this is low quality evidence. This was non-blinded. The outcome measures were not masked. And I think this sort of at the bottom line is that this study still leaves me with the question, how do we best support the preservation of functional and mental capacity for hospitalized older adults? I don't know that this really adds too much, sort of doesn't really help me answer that question to a great extent. So just quickly, this is the study due in 2022. This is the STRIDE study that's a follow-up to that 2014 study. This is going to be pretty big, 15,000 participants at 8 VA sites. And so I look forward to reading that study, which should be coming out in 2022. I'll take questions now. Thank you.
Great. Thank you very much, Christina, for the clear and excellent appraisal. Dr. Jennifer Watt has prepared a question in advance. Shabir has a comment in the chat box, but Jen, if you can please unmute.
Hi, so great job, Christina. I read this paper and actually you identified a lot, like all the concerns that I did. I agree. I'm not sure that this changes my mind on anything either. And so knowing sort of everything that you identified, if you were to design this study again, or, say you were working, or I know, we're talking about the STRIDE study, so, we're a little bit excited about that one and the way it's being designed, but this study here in particular, if you were to design the study again, what 2 things would you do differently and why?
So great question. Thank you. I would 100%. I think it's impractical to blind this study. Obviously, it needs to be unblinded just because of the nature of the intervention. But the outcomes assessment, I think, should 100% be masked. Otherwise, there is a high risk of bias. That's the first thing I would do. And then the second thing I do is, well, there's lots of second things, but I guess the most important thing, it would be nice to see some like 30-day or 60-day sort of long-term measures, like follow-up measures. I think that would be an important, like patient important thing, as well as measuring delirium and MMSE. Like there's lots of other outcomes that I would have liked to see.
And then one thing I noticed, and I'm not sure if I just missed a detail somewhere or just point of clarification for everyone, is that in the exclusion criteria, they state that you'd be excluded if you were independent, if you had independent walking ability at admission, and that was a lot of people. That was 520 people. But then whenever you look at like the Braden activity subscale scores, like at baseline, about 3/4 of the people were like, you know, walking, or the equivalent of walking outside the room at least twice a day. Like it seems, so I'm just not sure how they decided to exclude these people who are independent and walking at baseline. If you could have any more details about how they decided to exclude those people.
Yeah, I agree. There was a paucity of details around that. All they said was that this decision was made by the geriatrician on the unit, and that's all they said. And there's nowhere in the supplementary information. So I agree that's an issue.
Okay, thank you.
Great, thank you. Two comments. Barry and Shabir both offer congratulations on a great or nice presentation. Shabir also comments, at the end of the day, are the results for all of its faults believable? Do we have strong reason not to try to implement?
Yeah, I mean, like I think in a unit that doesn't have physiotherapy or OT, like I really just thought, and I don't think I realized that when I skimmed this study. And then when I really got into the weeds, I thought, oh, this is really just assessing what we already do. It's just that there's a trained nurse doing it instead of physio and OT. So yeah, I mean, I guess I would just say that this is, I think we can all agree that mobility interventions in hospital are really important. I think that it's still a little unclear, like what type is most important. Like this was just walking. Should we be doing more resistance exercises? So I think I'm just still not sure about that. But yeah, this study just is what we already do, actually, because I would say that most physiotherapists and occupational therapists see patients maybe not 30 minutes daily, but almost as much in many of our acute care units.
Great, thank you. A few more comments. Dina says it would be nice to see this sort of program applied to a setting more representative of our own. And Christina Lee would like to see the effect of additional walking programs on top of usual PT-OT care, and what the threshold is for significant effect. And lastly, Gary adds, because increased resources are needed, there is a need for evidence to support the intervention. So with that, I'll close the question and comments to the short presentation. Thank you very much, Christina, during a very busy time of your year for a great presentation. And we'll now transition to Dr. Dina Sommer, PGY4 Geriatric Medicine, who will present on the effects of vitamin D on falls, something that we grapple with multiple times per day. Dina, please share your slides.
I don't know how to get out of that.
That's perfect.
All right. Thank you so much, everyone, for being here this morning. Thank you, Christina, for a great first presentation. This morning, I'm going to be talking about the effect of vitamin D on falls prevention in older adults. The study I'll be discussing today is called the STURDY trial, published in the Annals of Internal Medicine in December 2020. And for those who are interested, STURDY stands for the Study to Understand Fall Reduction and Vitamin D in You. I have no conflicts of interest to declare. So objectives for today, we'll talk a little bit about some of the context and background We'll go through the study design and methods. We will then critically appraise the study and then discuss the application to our practice. So I wanted to frame my discussion today around a typical case based on a real patient with details modified. So this is Mrs. OHD. She's a 79-year-old woman. She's actually a retired nutritionist, and she was referred to clinic because of fear of falling. She has had 2 previous falls resulting in arm and wrist fractures and is now very scared to mobilize, and this is impacting her quality of life. She uses a cane or walking poles to get around, and she by self-report gets adequate calcium and vitamin D from a fortified diet. And this is her area of training and expertise, so she's very mindful of these things. We performed a workup for osteoporosis, and she was at high risk for future fracture. And her vitamin D level was 69 nanomoles per liter, which is below the optimal threshold of 75. So the question for her is, should she take vitamin D for falls prevention specifically? And that's where the STURDY trial comes in. So the STURDY trial poses 2 main research questions. The first question is, in adults age 70 or over with moderately reduced serum vitamin D levels, what is the optimal dose of supplemental vitamin D for falls prevention? And then the second question is this optimal dose of vitamin D, is it actually effective in preventing falls? Why is this question so important? Well, I think all of us here today know that falls in older adults represent a major public health burden. According to the World Health Organization, about 1/3 of adults over the age of 65 fall each year, and many of these falls result in major injuries, disability, institutionalization, and death. The vast majority of hip fractures are caused by a fall, and we know that up to 20% of patients with a hip fracture will die within a year. We also know that after a first fall, the chance of a recurrence of fall increases to about 2/3 in the next year. So falls lead to this vicious cycle. The first fall may lead to a fear of falling, which may then contribute to reduced physical activity, social isolation, reduced quality of life, again, adding to deconditioning, functional decline, and putting a person at risk for recurrent falls. Now, in this context, vitamin D supplementation has been hypothesized to potentially reduce falls risk in older adults. Where does this hypothesis come from? Well, there's a few kind of pieces to this. The first is that in people who have severe vitamin D deficiency, you'll often see a significant myopathy. So there's a hypothesis that with increased vitamin D, you can have an effect on muscle strength and potentially reduce that falls risk. Additionally, there is a vitamin D receptor that is present in muscle tissue, and activation of this receptor has both genomic and non-genomic effects. And finally, in animal models where that vitamin D receptor is knocked out, even from a very, very early on, pathologically, there are morphologic changes to muscles in these animals. So a lot of potential for the theory that vitamin D has impacts on muscle function. So with this hypothesis, there have been previous studies on this general question about vitamin D supplementation and falls prevention. And these trials have had very mixed results. So earlier trials that looked at this question typically showed reduced falls risk of up to 20%. Then there was a series of trials that really didn't show much effect at all. And subsequently, later studies that looked at high dose vitamin D supplementation actually had suggestions of increased falls risk and maybe even increased fractures. You can see here, this is a graph from a 2018 study that suggested there may be a U-shaped dose response curve for vitamin D supplementation and falls, with those middle doses seeming to have lower falls risk compared to the lower and higher doses. So I've tried to put together this slide here to summarize some of the evidence over time. Abstracts that are highlighted in green showed falls prevention. Abstracts highlighted in yellow showed no effect, and those highlighted in red actually showed negative impacts or increased falls risk. And you can see that the progression over time, initially there was, things looked quite favorable for vitamin D for falls prevention. And then the more recent studies have been quite a bit less favorable. But you can also see that the doses that were studied in these trials are extremely variable, going from 200 international units per day of vitamin D up to an annual dose of 500,000 international units. So a lot of variability in the methods and the doses. With this context, back in 2012, the US Preventive Services Task Force made a recommendation suggesting vitamin D supplementation as a falls prevention strategy. However, with the new evidence that came out, this recommendation was actually revoked in 2018. There are a lot of reasons hypothesized for the differences amongst trials, including different modes of administration, differences with compliance, whether or not calcium was also supplemented. But of course, one of the biggest questions here is the dose. And that is one of the main impetus behind the STURDY trial. So again, the STURDY trial published in Annals in December. So what did the STURDY trial actually look at? Well, the primary outcome of this trial was time to first fall or death within 2 years. Interestingly, in the protocol of the study, the investigators didn't specify exactly which groups they would be comparing to the control for this primary outcome. So ultimately, after the fact, they decided that they would compare all patients who had ever taken the best dose to the control for their primary and secondary outcomes. The secondary outcome that they looked at was change in gait speed, which they measured from a timed 4-meter walk portion of the short physical performance battery. The study design is a bit complicated. It took me a while to understand what they actually did. So please raise your hand for questions if there's any clarification needed here. So the study was a 2-stage study with 2 phases. Phase 1 was the dose finding phase of the study. In this phase, participants were randomized either to a control dose of vitamin D, which was 200 international units per day, or to a non-control dose, which was either 1,000, 2,000, or 4,000 international units per day. 50% of participants were randomized to control, and then the rest of the participants were evenly distributed among the other groups. Then during this dose finding stage, the results of the results in those 3 treatment arms were compared to one another to identify a best dose. Once a best dose was identified, then the confirmatory stage started. And in this stage, all participants who were taking a non-control dose were then switched to the best dose, and the study was to continue. The next slide here, it's a busy slide, but I'll just use it to frame my discussion about the methods. So I mentioned that during this dose finding stage, the goal was to identify the best dose of vitamin D. So the way this worked was that at pre-specified time points, and that was every time 100 participants reached 6 months of follow-up, then the investigators would do an analysis of the data that existed, and they looked at the posterior probability that each of those 3 doses, either 1,000, 2,000, or 4,000, was the best dose. And then they would apply that probability to affect the chances that new participants would be randomized to a certain dose. So just to kind of make that a little more clear, you can imagine that as one dose starts to look more favorable as the best dose, more participants start to get enrolled into that group and fewer participants are enrolled into the other groups. The study investigators pre-specified that a dose of vitamin D would be declared the best dose of vitamin D when the probability that it was the best dose was greater than 95%. And doses were supposed to be eliminated from randomization when the probability that they were the best was less than 2.5%. Unfortunately, in this study, there were some significant deviations from this protocol. So as the study was being conducted, in March of 2018, the Data Safety and Monitoring Board noticed that, that there was increased risk of falls in the 2,000 international units per day group. So with this recognition, they recommended that randomization to that dose stop, even though it hadn't met the pre-specified threshold for being eliminated from randomization. Very shortly after that, they had increased scrutiny on the 4,000 international units per day group, and they noticed increased hospitalizations in that group compared to the controlled dose. So again, they recommended elimination of that dose from contention. And what's really notable here is that the 4,000 units dose, it had actually been doing better over time. So certainly it wasn't doing very well. The probability that it was going to be the best dose was somewhere in the 7% range, but it had been improving and it was eliminated from contention. So ultimately 1,000 international units was declared the best dose, even though those pre-specified outcomes had not been met. Now, this is a really complicated study design. I know I've thrown around a lot of numbers, so I just want to pause for a moment and ask if anyone has any questions or clarifications about this.
Thank you. Thanks, Dina.
So how did they define, what were the criteria to be the best dose or the optimal dose?
That is a great question. So they were looking for the primary outcome measures, which was first fall or death, but they were only comparing those 3 treatment doses to each other. So they were not comparing to the control when identifying the best dose. And then they did some complicated statistical analysis, which is beyond my understanding, using Bayesian theorem, comparing the posterior probabilities.
And Dina, can I ask too, with so many tests being run or analyses being run, did they have any adjustment or change in their threshold for significance?
That, you know, I'm not exactly sure about that. I think that was incorporated into their model for identifying which dose was best, but I didn't specifically see anything about adjusting the significance on that.
Can I just make one point of clarification? And forgive me, Dina, if this is sort of what you said and I misunderstood. But I think it's just an important point for everybody to know, because as you're pointing out, it's complicated methods, and then they didn't always follow exactly as their protocol should have been. And so then when you were talking about the primary outcome, that was good. And then when we were talking about like who would be included in that analysis group, I think as you highlighted, what's really good is, you know, our control group ended up being the people who got the 200 units of vitamin D. And then though, for the people who, when we were looking at our sort of time to event analysis, you have all the people who were originally got 1,000 units a day, of course, who end up kind of flowing through your figure. figure number is that? Sorry, figure 1, the part B. But then the people who were originally in the 2,000 units a day and 4,000 units a day, who then got sort of once they figured out the best dose, and then they were getting distributed the 1,000 units a day, the time during which the people got 2,000 units a day or 4,000, like those people, once they got switched into the 1,000 units a day group, their events started to count as well. Yes. So it was kind of like, it was kind of neat that way, in that they were trying to maximize their sample size for that optimal dose once they determined it.
Yes, absolutely. And the primary events, they were only counted while they were taking that optimal 1,000 units dose.
Exactly.
Thank you, Jennifer. Shabir has his hand up as well, but I think for the sake of time, Dina, why don't you finish your slides? And I'm sorry, Shabir, but we will get to your question at the end.
Okay. So the study calculated a sample size of 1,200 participants, expected to achieve a result of 400 falls. And this was supposed to provide an 80% probability of finding a best dose and a greater than 90% power to detect a hazard ratio of 0.75 for first fall or death. The median time observed in the trial was 22 months. And I found it really interesting to see that they calculated the expected days of follow-up. And participants were followed for almost 94% of expected days. So really good follow-up in this trial. The table 1 that was provided in the paper is shown here. The study included community dwelling older adults aged 70 or older who were at elevated falls risk on the basis of either 2 previous falls in the past year, 1 injurious fall, fear of falling, difficulty with balance, or use of a gait aid. And they needed to have a serum vitamin D level that was between 25 to 72.5 nanomoles per liter. I found this a bit interesting because there is some controversy about what constitutes the optimal vitamin D level. And this range of vitamin D levels includes it includes ranges that are termed deficient, inadequate, or adequate by the Institute of Medicine, and it includes levels that are termed deficient or insufficient by the Endocrine Society. So there's a variety of opinions there. Participants were excluded from this study if they were cognitively impaired, had a history of hypercalcemia, GU stones, or were using doses of vitamin D or calcium at baseline that were higher than listed here. So you can see here, the table 1 doesn't compare between groups. It just gives you a sense of the baseline participant. The supplemental data did include comparisons between groups. I don't expect you to be able to see what's listed here, but I'll just point out that on my overview, I think that there are some differences here that could potentially be significant. For example, race, there were more people classified as Black or other in the 1,000 international units dose, so the ultimate best dose. There was differences in baseline vitamin D levels. So for example, in the best dose group, there were fewer people who fell into the very low vitamin D level category of 25 to 49 nanomoles per liter. There were 22.3% compared to 36.8%. That seems like a potentially significant difference to me. Frailty status, there were maybe some differences there as well. The best dose group had 25% of participants classified as robust compared to 37% almost in the 2,000 international units group. So I don't have statistical analyses to tell me there's significant differences, but certainly there's some potential for differences between groups here. So now let's look at the results. The first graph here is Kaplan-Meier graph of the composite primary outcome of first fall or death during the dose finding stage. And you can see here that there is some distribution. The 1,000 international units per day group, the ultimate best dose group, looked like it was doing maybe a little bit better, but it's not dramatic to my eye. And then looking at the next graph, this is the experience with best dose category. So again, as Dr. Watt explained, These are all participants who were ever taking the best dose and analyzing only the period of time where they were on that best dose. And here it's pretty obvious, those curves are tracking along with each other. There's no clear separation between the curves and no clear difference identified. This is the same data in table form. We can see that there was no significant difference identified in the primary outcome when comparing either the experience with best dose group or when they compared all higher dose, the pooled higher dose group. So anyone who took a higher dose than 200 international units, there was no differences in either component of the primary outcome or the composite primary outcome. And there was also no difference in gait speed identified. This is a figure from the supplemental data. And here they looked at the primary outcome in various subgroups. And you can see that there was no significant differences identified in any of the subgroups that they looked at here, from age to frailty status to baseline vitamin D levels. How about adverse events? So there were some significant differences here. I think quite interestingly, there was actually an increased risk of a first serious fall or a first fall with hospitalization seen in the experience with best dose group. And I think that was probably a bit surprising. There was no differences seen in, or no concern for vitamin D intoxication seen in this trial. So what can we say about this study with respect to critical appraisal? Well, there were a lot of strengths to this trial. I think it was a relatively well-designed, internally valid trial. The participants were randomized appropriately. They were blinded. Everyone received the same pill bottle. The pills were identical. Groups were treated equally with respect to monitoring and follow-up. There was rigorous fall ascertainment in this trial, with falls monitoring calendars, frequent calls, frequent check-ins, and those falls were actively sought out, and there was good follow-up. So whenever a fall was identified, there was a lot of data, further data collected. There was very little loss to follow-up in this trial. And although there was this issue of the primary outcome not being entirely pre-specified, there were consistent results across the sensitivity analysis, comparing both the experience with best dose group and the pooled higher dose group, which suggests that those results hold true. With respect to external validity, I do think that the enrolled participants are representative of many community dwelling and cognitively intact older adults. So I do think that we see patients like this in our clinic. How about the weaknesses? Well, there were some differences between groups which may have affected the ability to detect true differences. The analysis was not intention to treat, so they only included participants who ever received that best dose, and not participants who would have been randomized but never received it. There were some deviations from the study protocol in determining the best dose, as I mentioned. And also a big question here is the control comparison in this study was a dose of vitamin D. So when we're trying to determine the best dose of vitamin D, how do we know that 1,000 international units is the best dose when it wasn't actually compared against this control dose, which was a lower dose? Additionally, cognitively impaired participants were excluded, and that represents a large proportion of patients that we see in clinic. So certainly hard to apply the results to those patients. So what is the bottom line here? In older adults who are at increased falls risk, who have suboptimal serum vitamin D levels, supplementation with 1,000 international units per day was not effective for falls prevention when compared to 200 international units per day. There is some concern for increased falls, increased injurious falls at higher doses, and maybe even at this best dose, observed in this study and in other studies. But of course, of note, our guidelines continue to recommend vitamin D supplementation for adults over 50. The key point here is the goal is fracture prevention, not falls prevention. So returning to our case, Mrs. OHD, I think I can be confident in saying that there really isn't a benefit for this patient in terms of supplementing vitamin D for falls prevention. But the question then is raised, would you start this patient on supplemental vitamin D for fracture prevention? And coming into this, I thought, of course, yes. But reading through some of the background literature, I would say that even this question is a little bit less certain. The data, especially in community dwelling adults, is not so clear. There was a recent meta-analysis that included over 34,000 participants. And in this meta-analysis, they did not see a benefit for fracture prevention in community dwelling older adults with vitamin D supplementation. So, it's a little bit of controversy, and I would love to hear thoughts from the audience. And I'd like to open it up to questions and comments now.
Thank you very much, Dina, for skillfully getting through a complicated trial design. I'll just summarize a few comments in the chat box before the questions. Barry, as mentions, as Dina, you did as well, just a reminder that for nutrients, deficiency is easier to identify than optimal. And Shabir commented, it's a good summary of complex adaptive randomization design, but 2 protocol deviations don't help and ultimately undermine the study. And Gary had a question, did the analysis adjust for baseline differences in the groups?
There was no note of adjustment for those differences, no.
Okay, and now I will turn to Jen Watt again, has a pre-prepared question. Unless you already asked the question, Jen, please go ahead.
So great job, Dina. As everyone's saying, this is a really complicated study, but neat. I enjoyed reading this. And so my point actually builds on one of the limitations that you mentioned. It just kind of to flush it out a little bit more. The authors kind of are of 2 minds. In the methods of their paper, they explain why they used the 200 units per day vitamin D dose as their control. And then in the limitations, they go on to say that, not having a placebo group was a limitation. And so I think it might just be good to talk about, the author's rationale for using the 200 international units a day of vitamin D, and whether or not you agree with what they did. Do you think it would have been better to have a true placebo or to use the 200 units?
You'll have to help me out here because I can't remember exactly what they wrote as their rationale. I believe that it was based on previous studies. Is that correct?
Yeah. So in the treatment section for the methods, they say the control dose 200 international units per day was selected because it provided reasonable assurance that average total daily dose vitamin D intake, so diet plus the 200 units, would be at least 800 units a day, which is the recommended daily allowance for the age group studied. So in effect, actually, the control group was getting, based on what they estimate, about 800 units a day, which means if we assume that, then the optimal daily dose, or that the experienced dose, was actually about the 1,000 plus an additional 600 from their diet. So it's, we say we're comparing 200 to 1,000, but based on their rationale, it's not quite actually what they thought they were doing.
And we're essentially obscuring the opportunity to find a difference here. If you're comparing people who are already on what is being recommended as the optimal dose for older adults, you're comparing that dose as your control, it's going to be pretty hard to find any difference there. So I completely agree. I also found it interesting that, the high dose vitamin D here was 4,000 international units per day, whereas in those other studies, the increased risk of falls was seen with really ultra high doses. And maybe that question has been put to rest, and maybe, it's known that that's a dangerous dose and that wasn't looked at. But the range to find the optimal dose I found to be quite small, actually.
Thanks, Dina.
Thank you. Shabir has his hand up again. Please.
Thanks, Dov. Dina, great presentation. Difficult study, but a very interesting one. I have a comment to Dov's question earlier about adjusting for multiple comparisons, and then a comment on your response and Jen's question about the vitamin D dosing, where I actually disagree a little bit. So I want to put out a different position. So Dov, because this is not following a classic frequentist statistical approach where you're looking at absolute p-values and one primary outcome or multiple significance testing, in that kind of classic frequentist approach, you would be adjusting for p-values with something like the Bonferroni or other method if you're doing multiple data comparisons. This is a Bayesian approach, and in certain classic Bayesian analyses, it's a very different concept and different framework, and traditionally people do not do adjustment for multiple significance testing because the framework is a very different one in which you start with a pre-test probability, or what they call a prior, and then you add in information from the current study plus or minus other studies and get a post-test probability that's based on all the new information, and then that is compared to a specific threshold. So for example, 97.5%, 95%, whatever. Many of these are borrowed from frequentist approaches, but it's not the same approach. And so traditionally, they don't do adjustment for multiple significance testing when you're following a Bayesian analytic framework. Rightly or wrongly, it is criticized for that, but it has proponents who explain why you don't need to within a Bayesian framework that we don't have time to get into here, and I don't have the statistical expertise to probably deal with them in an intelligent way anyways. Jen and Dina were talking about this low-dose vitamin D. So I want to point out, and then I have a follow-up question on that because I couldn't access the supplemental materials right now. I think a logical question many of us would ask, if we're really thinking about vitamin D and mechanism, is in the people who are deficient in vitamin D at baseline with very low levels, did they do a stratified analysis? And I know they're probably underpowered to see whether people who started off at very low levels of like less than 20, or not less than, but between 25 and 40 or 25 to 50, whether they did well as well. And great, so you've got that. But if you're thinking about the comparison of 200 versus 1,000, physiologically, multiple studies have been done in humans and non-human studies where they look at the dose of vitamin D and changes in vitamin D levels over time. And it is not a log linear or non-linear relationship. It's generally fairly linear. So what we're doing is we're looking at the addition of 200 units to the addition of 1,000 units or best effective dose. And people started off on average at 600 units a day, and many of them still had fairly low vitamin D levels. Their diet didn't change. And so going from 600 units to 800 units a day is relatively small. It's a 25% increase in vitamin D, but the change in level will be quite small. So for most physiological arguments, it's probably almost the same as placebo. Some people don't agree, but my feeling from the bone world, from my limited knowledge there, is that 200 units, if we did a placebo versus 200 units, it wouldn't make that much difference. Dina, you've got the subgroup analysis here. Can you walk us through this?
Yes, so they, it would have been helpful maybe if they had even added some additional breakdowns here, including baseline. It would have been interesting to see more about the baseline vitamin D supplementation. I don't know can you see my cursor?
I can, yeah. It looks like it's an absolute dud between the 25 to 46 versus, or 25 to 48.5 versus 49 to 78.5.
Exactly. So you can see that even between those two groups, there was really no difference here comparing those two groups. And then they do have people who were taking some vitamin D at baseline, and you can see there was no real difference there either. I wanted to thank you so much for the explanation about the Bayesian probability. I understand it a lot better now, so I appreciate that. To add to that, I think that the 200 international units per day dose may have been very reasonable, but they also included people who are already supplementing. So, the 200 is not 200.
It's
maybe
true.
Yeah.
Yeah, I mean, yeah, it's a complex trial with many nuances. At the end of the day, they don't report formal interaction terms, but there's no signal here on the subgroup analysis. It looks like it's a dud, whether you have low vitamin D levels or relatively low, as opposed to severely low levels or not. And as you rightly point out, maybe if we're thinking of vitamin D, we should obviously be thinking about fracture prevention, but for falls prevention, there's really growing evidence that there's just no good data here. And I, for one, was a previous proponent of it for falls reduction, but I have had to change my mind. The evidence is getting stronger and stronger.
Thank you very much for a great discussion. There are a few more comments in the last moments. Gary says the trend to updosing vitamin D has been a significant issue. If some is good, more is not necessarily better. Vitamin manufacturers have prospered. Maybe the lesson is that we should go back to nutritional basics of 800 international units per day total daily requirements, and also states other possible indications for vitamin D supplementation in preventing diabetes with a reference. And Barry Goldlist, Salim Yusuf in his sodium studies commented that for all things in nature, there is insufficient and too much. Goldilocks was the expert in determining what is just right. And Murray has her hand up. We have just a few seconds left. If you have a quick question or comment, please, Murray.
Just a comment. We always say falls is multifactorial. And in order to address it, we have to target all reversible factors, such that a one item intervention such as vitamin D is bound to not be effective. I think we should stop studying that.
Great comment. Thank you, Murray. So thank you very much, Dina. We appreciate it greatly.